Well, first, a hip is a ball and socket joint, and the femur has a ball in it, and the pelvis has an acetabulum, which is a socket, right? And they are like that, and so that's the ball and socket joint. And then what we do is remove the ball from the end of the femur, and then we have access to the socket. When we do, then we clean out the socket, take out all the residual cartilage that's in there, and put in a metal and plastic socket like that. It fits up in there and becomes the new socket for the pelvis. And then the femur is cleaned out in the marrow space with progressive rasps so that it is then shaped like this, which is the internal shape of the femur naturally. And then this is titanium, and it's placed down inside the femur and becomes the new ball on the end of the femur. And then they go together as the new ball and socket joint, like that. We've done hip replacements on teenagers, and we've done hip replacements on 90-year-olds. And really, it's someone where the ball and socket's been injured or destroyed through some disease process, typically osteoarthritis, but also rheumatoid arthritis, other types of arthritis, lupus, avascular necrosis. Those patients are in pain, they're limping, their life has been disturbed, they don't sleep well, they can't walk very fast, they can't climb stairs. Those are the people that we are aiming to help. Outpatient surgery has come about because of a couple of things. One is doing the surgery under spinal so that we have very good pain control, and when the spinal wears off, the patient isn't nauseated and feeling terrible. That's one thing. Then we also do these injections inside the joint, which numb the joint for the first day or two, so people have very, very little pain on the day of surgery. We also use a drug that limits their bleeding, and that has helped us a lot, made it a lot safer. Let us do it in the outpatient setting so we don't have to transfuse people. We give them multiple minor pain medications from multiple different directions that prevent pain from occurring in the first place, or at least keep it at a low level. And so we can minimize our use of narcotics, and that helps in a lot of ways. In the outpatient setting, they do the surgery, the spinal wears off, the physical therapist comes and sees them and stands them up and walks them. This may be an hour after reaching the recovery room. And typically they can walk up to 200 feet. They have to prove that they can climb stairs if they have stairs in their house. They've got to get on and off a chair, a toilet. These are things that you have to do to function to go home. Then they go home, and it's better if they have a sort of designated caretaker when they go home. We like for a family member or somebody like that to be with them for the first 3 or 4 days. After hip replacement, what typically happens is patients are on a walker or crutches for up to 2 weeks, maybe even up to 3 weeks, depends on what they come in with strength-wise. And then after that, they use a cane for a little while. They're able to put weight on the hip right away, able to walk 200 feet, get in and out of bed, on and off a toilet. Those are criteria to be able to go home. They do physical therapy for the first 6 weeks typically, maybe sometimes a little shorter, 3 to 2 times a week. And after about 6 weeks, they're pretty normal. They're sore after activity, but pretty normal. And then at 3 months, people resume significant hiking, meaning hiking 3 miles, that sort of thing. They're able to live their lives after 4 to 6 weeks.